I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. I think I've actually been hiding something from us, and I'm going to use today's podcast to be a bit of a change in direction. And this might sound so silly and so small, and maybe if I didn't call it out, that you wouldn't actually notice this slight change in direction. Welcome to Women's Health Unplugged. I'm Dr. Jordan Robertson. I'm a naturopathic doctor, but I'm actually an expert at what's called critical appraisal, which is the reading of research, the deciding if research is relevant, if it should support clinical change, meaning that should doctors change the way they practice based on new research that has come out, which maybe you knew. But I don't think what I've done well in the last couple of years is actually taken a stand on certain conversations. I don't think I've actually shown up quite as authentically as I should be to help you really understand the difference between right and wrong online. And I've definitely walked this very careful conversation of not wanting to offend people, not wanting to become part of the negativity that is common online. And I think what I've noticed watching this conversation is that there's people who say things that aren't true. And I don't not even know if they know that it's not true, but there's professionals that say things that aren't true. And then the people who counter those things are often doing it with negativity, with not a lot of compassion. And it turns into this sort of she said, sort of bullying type conversation from both parties online. And I've never really wanted to be a part of that. I've never wanted to be like this naysayer that was going to jump in and, do those incoming stitch kind of videos where now I'm going to poo-poo on somebody's business and somebody's Instagram page because what they're saying is batshit crazy. I've never wanted to show up like that online. And yet, by not addressing some of those things, I think, one, I'm not acknowledging my skill set and my true area of expertise that well. And I'm probably not equipping you with what you need to make good decisions. Like, no wonder people are so freaking confused about their health. So I want to talk about breast cancer screening today. And in that, I want to call out some of the untruths you see online. I'm going to try and do this in a very compassionate way, but also in a way that helps you be able to spot and recognize things that are not true so that you can make good decisions for yourself. I also am going to talk a little bit more about how we make decisions in research so that it's not just, well, Jordan said this and this other person said that. That's not really what it is. Like, we actually have like a framework for how we should be thinking about and making decisions in science and in medicine. And maybe if I show you some of that a little bit, that might help you understand why we say the things we do or why we believe the things we do, why public health is shaped the way it is. And then if you want to choose to believe the opposite of that, that's totally up to you. But at least I've shown you how we've made the decision around what is our current sort of truth in science. The idea to do this particular topic was sparked by a conversation I had with a healthcare professional who was against breast cancer screening. And I sat back and listened to the conversation And as I was sitting there, I was like, I don't know how to have this conversation with this individual because they had really built their life and career around what they believed, and it's not right. And that just felt very difficult. So I was like, well, that's really not for me to change that one particular person's mind, but I do think I can do a better job of having this conversation on my own platform. So here we are. Screening tests are unique. Okay, so I do want to call out the difference between research on tests and research on other stuff, right? And I think when we think about supplements or drugs, and if I explained to you how we research them, we give some person the supplement and some people get like a fake one. And then at the end of 3 months, we look at and see who got better, right? Like that makes sense. That's how we would go about studying a supplement. Sometimes we forget, even as clinicians, that lab tests actually also have to be studied. That testing deserves to have the same level of scrutiny as we would have with a supplement. So if we gave a supplement to 100 people and a fake supplement to someone else, and the people that took the supplement didn't get any better, we'd be like, well, that didn't work. And labs actually should be subject to very similar conversations and similar studies where we give people a test and we track whether it changed their outcome, whether it performed any better than other tests we use, right? Like technically we are supposed to study tests exactly the same way that we study supplements, with a couple of little, nuanced changes, because when you're studying a blood test or a scan, it's a little bit different than giving someone a pill, right? So of course we have to account for that. But screening tests are unique. For a screening test to be effective, it actually has to satisfy a couple of requirements. And I think once I say them out loud, you'll understand what this means. But a screening test, just by definition, means that we're going to give it to large groups of people with the ultimate goal of catching people at a time that we can make a difference. And overall, in that entire population of people, reducing the number of people who get a disease, reducing the number of people who have what we call morbidity, meaning that they suffer from their disease, whether that's loss of work time or disability or what have you. Or we want to prevent mortality from that disease, or we want to prevent people from going down a treatment path where they need to have a more invasive treatment done at a later date. So I'm going to just say that again. When we screen large groups of people, we're trying to prevent a percentage of those people from having a negative experience or outcome from a disease that may result in death, but may just also result in lots of other things that we don't want them to have. We're trying to reduce the percentage of people that are going to have a negative outcome by taking a whole bunch of people and actually testing them in advance to see if we can figure out if they're going to get that condition or disease. That is a screening test. That's very different than a diagnostic test, right? If we were going to try and diagnose you for diabetes, we would look at your personal history, your signs and symptoms, the likelihood of you as an individual having diabetes, and then we would make a single decision about you in that moment, whether we should test your blood sugar or not. And we actually probably have this, what we call pre-test probability. We have a pretty good idea if you're going to have diabetes or not, and we test you as an individual. Screening is different. Screening is saying, what if we gave everyone a blood test for their blood sugar every year so that we could catch people before they even had a negative consequence from diabetes, before they even started to have their blood sugar go up? It's a very different conversation. I know that may sound incredibly nuanced if you're listening and you're like, Jordan, I am not a doctor, but trust me, I need you to understand this because it will help you understand the screening piece. Screening is large amounts of people having a test at a time that we can try and take the people who are on a path towards that disease off the path. It's not about your personal risk. It's not about what we think about you as an individual. Very different than when we tested you for diabetes, you as an individual. Screening is about statistics. It's about the entire population. It's about the greater good. It's about giving you access to something that tries to find something that we couldn't find otherwise. If we could find out if you were going to get breast cancer just by, taking your fingerprint or doing a retinal scan, like we would do that. But we can't. So we use the methods we have available to us to try and find out if you are on a path with your health that we want you to step off of. So screening has to satisfy a couple things. I've alluded to a few of them, so I'm going to repeat myself a bit, but let's say them out loud again. Screening has to catch you at a time where it's important. Right? If we offered people a screening test for some made-up disease and that screening test only caught you 48 hours before you were about to die, that's not very helpful. If a screening test caught you at a time where we couldn't do anything for the condition, it's not helpful. If a screening test catches something 80 years before it's going to happen, it's probably not helpful. Right? You catch my gist here around the timing. It has to catch you at a time where we can have a tremendous impact to your course, where we can say, like, tap you on the shoulder and say, if we don't do something, something bad will happen. That's what a screening test is supposed to do. If we catch you too late, it's not helpful. If we catch you too early, it's not helpful. If we catch you at a time that we can't do anything, right? Nobody wants to be tapped on the shoulder and said, hey, something bad's about to happen and there is nothing we can do, right? Screening is about finding the perfect timing in order for us to support you the best we can to have the most positive outcome. So specifically talking about breast cancer screening, because that is what we're going to talk about today, Ontario specifically just changed the age. Right? And when some government changes happen like that, sometimes we're really quick to be negative. It's a cash grab. They just want to do more mammograms. Is it though? Or is it that we realized that when people are in their 40s and they get breast cancer, it's actually really aggressive. It's more aggressive than the people who get caught in their 70s. And so the timing suddenly became an area of interest. By changing the timing of when we started, we could actually catch people at a time where we could get them off the path. So instead of that woman getting tapped on the shoulder at 50 and us saying, oh shit, you have a very aggressive form of breast cancer, we're tapping her on the shoulder at 42 saying, I think we found something. The timing is everything. And that age bracket between 40 and 50, maybe the number of cancers we find is low, but the ones we do find are important. And that's why they changed the age. They changed the age because the timing matters. They changed the age because tapping those women on the shoulder, even if there's not that many of them, we caught them at a moment that we could dramatically change their lives. That's why they changed the age. So that's one thing that screening has to do. The timing is incredibly important. It also has to be something that we can change the course of. Like I said, if we tap someone on the shoulder and we're like, hey, guess what? There's nothing we can do. That's not helpful. But for certain diseases, and breast cancer is a great example, our treatment success is phenomenal. And so we want to find those women because we can help them, right? We want to tap those people on the shoulder as early as we can because we can change their life. We can change their likelihood of having mortality from their breast cancer if we help them. And we can. And so finding those people at the right time actually means we can change their trajectory of their life. So that's another thing that a screening test needs to do. We don't screen for hangnails because they'll get better on their own, right? We don't screen for things that are self-limiting. We screen for things that have a tremendous impact on that individual's life. So that's another thing that screening tests need to be able to do. The timing is important. We also need to be able to change the trajectory once we do find it. Screening tests also have to be accessible. They have to be low risk. Because if we want to distribute something to the masses, one, we need everyone to be able to get it. And two, we don't want to hurt them more with the screening test than they would have if we just left them to their own device, right? You know, if the screening test cut off your arm, I'd be like, I don't know if that's really worth it. But the screening test itself needs to be relatively harmless compared to the outcome of being left alone and not finding breast cancer. And it also has to be accessible. So sometimes online you'll hear of other options, or you'll hear of someone who said, well, I had an MRI, or I had this other thing, which we'll talk about the other things in a second. And sometimes there are screening options for various conditions that maybe are more accurate or less invasive than the other options that are being offered by public health. But in order for something to qualify as a screening test, it has to be accessible. I don't know about you. I got in line for an MRI for my knee, and I know my knee is like not life-threatening, but it took me 9 months to get in. Mammogram is much more accessible than MRI. It is harmless. No matter what you read online, it's harmless and it's accessible. Perhaps MRI is slightly more accurate in certain breast densities, etc. I'm not going to say that that's not a valid argument, but we're talking about a screening test. I'm not talking about you as an individual with the funds to fly to Morocco and have a personalized MRI spa day and you come home with your report. I'm talking about how do we get screening into the hands of millions of women at the same time. That's what screening is. So yes, maybe you'll see a celebrity or someone you trust or someone with a big voice talk about what they did. That's an individual. When we talk about government recommendations, we're talking about the masses. We're saying, how do we get women from rural communities to have the same chance at life as women in urban centers? We're talking about how do we get the most number of people through and into a system as possible. That's why we recommend mammogram. It's safe, it's fast, it's accessible. And I know if you live in a rural community, it's probably not as accessible as I'm making it sound, and I am sorry about that. And hopefully with this advanced screening options that we do get more sites and more accessibility for people having mammograms earlier. But generally, that's one thing that a screening test has to be, is it has to be accessible, because otherwise we're not screening, right? If it's only for the elite, it's not a screening test. A screening test is for everyone. A screening test is to put the most number of people through something to try and reduce our statistics on damage to the entire population as a whole. So if you have access to something better, that's great. But that doesn't mean that the recommendations for screening are wrong. Remember what screening's about. It's not about you. It's about all of us, actually. And I actually think that brings up one point around the way we consume information is that we tend to hear about like the one viral conversation about a particular issue, and we don't, just as lay people, get exposure to population-based statistics. The nature of the way we consume information online right now means that we hear about the viral situation. We don't hear about how many people are being saved, right? And I say this to patients often because they'll be like, oh, my doctor prescribed this and I read the reviews online. Like, has anyone gone online and said, yes, my blood pressure medication kind of lowered my blood pressure and now it's in normal range? Never. You know what people do when they write about their drug online? They're like, I know I lost all my hair when I started taking my blood pressure medication, or started taking my blood pressure medication and my cat ran away, and I know they're connected. That's what we hear online when people write about their experiences in medicine. And that shapes the way we feel about it. It's like they're giving a testimonial or an anti-testimonial about it. And we are way more likely to look at that and believe it than we are a written statistic that says, if we lower your blood pressure, we'll save your life, right? We're way more connected to the viral video on someone's negative experience. I think for so many reasons, well, let's not get into that. But for so many reasons, we're way more likely to be connected to that viral video of a negative review. And I always tell my patients, like, nobody goes on TripAdvisor and writes about the mediocre chicken. You only ever hear about their food poisoning. And that might actually prevent you from eating at the greatest restaurant you've ever eaten at in your entire life because one guy got food poisoning. And you will hear lots of conversation online about people who got breast cancer anyways, or who got breast cancer and they swear their mammogram caused their breast cancer, or whatever, cured their breast cancer naturally by, soaking their breasts in tea leaves. I don't know. That's what you hear. What you don't hear is that the decision makers made decisions not on that one person, but on millions of people. And it would be like gambling, right? It would be like me saying, where do you want to put your money? Where we change the lives of millions of people, or this one person who has a bit of a viral video? Where would you want to put your money? And you'd say, I'm going to put my money over here, right? If the cards are stacked over here on the millions, not the one, on the millions. And yet, emotionally, we're compelled to still listen to that one viral video. When we create screening guidelines, we're not doing it to hurt anybody. Like the irony, right? Like the government and these special interest research groups and all these people spend their life's work trying to figure out how to save more people by slightly changing the age that we start screening or something, right? Like whatever the screening test is, and we're talking about breast cancer, we slightly change the age of the breast cancer screening guidelines because we know statistically that it can save more people if we do it. And do you know what people's reaction is? I don't know if I trust that. I once saw a video, ... And I'm not asking us to be unemotional about this. Breast cancer is a very emotional conversation. One, it's incredibly prevalent. And so we all know someone who's been touched by breast cancer, if it's not us personally. It's also our breasts, which is a very emotional part of our body and something that I think is very intimate, and there's a lot of fear around it. So I'm not saying be unemotional, but I'm saying stack the deck. Saying use your emotions to propel you forward to make a decision that's based in logic, right? Rather than letting your fear prevent you from taking action. So what about the people that do say that this is a problem, right? And sometimes we'll have like seemingly very qualified people go against conventional screening guidelines. And they'll often say things. So I'm going to try and equip you with some ideas around why they may say the things they say so that you can try and read through some of that noise. So sometimes when we change the guidelines around screening, we find the disease more often, which technically that's why we changed the age, because we'd like to find it. However, sometimes that gets used as ammunition, that saying that the test itself is dangerous. So we find so much more breast cancer now because we're, doing x-rays on people's breasts and that's causing breast cancer. We changed the guidelines because we're trying to find it. And so finding it was the goal. It's not an important piece that mammograms may increase our detection of breast cancer. That's literally what we're trying to do. And we have to remember that the detection is the goal and the prevention of negative outcomes, right? Like I said, tapping you on the shoulder and asking you to get on a different path, that's the goal. And so we always want to look at outcomes, right? It's not about whether or not you have breast cancer. It's about what happens when you do have breast cancer. That's important. And if we change those screening guidelines and catch you a little earlier, we get to change your life. My expectation is that we're also going to start to cite old literature about mammogram detection and success rates in older populations and try and apply it to this new younger population that's getting new mammograms. So you may hear people that say, well, We've been doing mammograms for a long time, and they haven't changed the death toll from breast cancer in ages. But doing mammograms in people that are in their 70s is not the same as doing mammograms for people in their 40s. And so just like if I said giving this medication to someone who's 99 didn't change when they died, your first question would be like, well, what happens if we give it to someone when they're 40? It's a bit apples and oranges to compare older women getting mammograms and their breast cancer versus younger women getting mammograms and their breast cancer. So if you're seeing that discussion online about how mammograms don't actually help, your first question has to be, well, in who? Because the new recommendations are about finding it in younger women. And so we can't really look at the data in older subsets. And I'm the first person to admit that I am not an expert in breast cancer. I have people that work with me that do that. However, the difference between breast cancer postmenopausally and premenopausally is relatively well understood. And breast cancer in premenopausal women is a different animal. It's more aggressive. And that's why we want to find it earlier. That's why changing the screening guidelines helps. And so just like we make evidence-based decisions about supplements and medications where we want to know who we're studying, we want to know what their outcome was going to be, the same is to be said about screening guidelines. If we change the guidelines, we need to start talking about that age group as being the people who does or does not benefit, and not everybody else who's had breast cancer screening for a long time. We want to look at the age group that we're currently talking about, and it's younger women. So that might also be something you see online as these changes come about, is that we start to cite old literature, or we cite statistics from populations that are different than ours, right? So we're talking about Canadian or North American statistics right now, where, typically we had to wait until the age of 50 before you qualified for screening. There's other countries that do it differently. And there's some countries that don't really screen at all, or they do more opportunistic testing, meaning that they only send you for a mammogram if we think you have a lump, and they don't test regularly. We have to ask ourselves, is the data in those populations even helpful? And usually the answer is no. And so for this new age group of women that are going to have this opportunity, let's just talk about you. Let's use what we've learned about you and apply it to you. And so if you're reading online or you're seeing things online that are fear-mongering you about your mammogram, you have to ask yourself, well, who are they talking about? Because it sounds like they're not talking about me. And lastly, we also do see other screening suggestions or recommendations being made online, things like thermography. This is a very simple answer. There is no evidence for thermography. The end. There's nothing more to say about that. Okay, so here's what we're going to promise each other. I made a note at the beginning that I felt like I really haven't been calling out some of the BS that I see online as emphatically as I could be. And I'm going to make you that promise that I'm going to do that better. That's for you and me. We're going to do this better. I'm going to do this better for you. The promise you're going to make me is that you remain curious about research. But don't turn off the podcast. It's not as boring as it sounds. What I want you to get curious about is what you see online, and then what is closer to the truth. Right? How do we actually make those decisions medically? I want you to have a slightly better understanding about that. So that when you see a new test and someone advertises you a menopause screening test, which let's do that on another day, because please do not buy an over-the-counter menopause screening test. Just please. We'll talk about that at another time, but the same principles apply. Think back to what I said earlier. A screening test or a test that we do in advance of a condition has to find it at the right time. It has to be accessible. It has to be important. Like I said, we're not going to test for your hangnail. So I don't know why we're doing at-home testing for menopause at this point. But I want you to get curious about the reality of what you consume online, what you hear on podcasts, even mine. Let's be curious about the accuracy of the stuff that we see. And let's try and equip you with some knowledge so that you can go, I don't know if that's true. Or, no, you're right. Like, why would the government create an entire screening plan to give more people breast cancer? That doesn't really seem to make sense. I want you to feel more confident as you navigate that stuff online. So as those breast cancer recommendations have changed, and I'm speaking a little bit about my own personal geography here, but you should really get curious about the screening guidelines where you live as well. And if you feel like you're an outlier, meaning that you should be screened and that's not offered to you, then let's take that up with your healthcare provider. We're not usually holding mammograms behind closed doors and you're not allowed to have one. If there's good reason for you to have a breast scan, mammogram, ultrasound combination of the two, most healthcare providers are incredibly helpful to get you on that path, right? So if you feel like you're an outlier and you're 38, or if you feel like you're an outlier and you live in a province or state and it's not offered, let's ask for one, okay? Because it's incredibly effective at screening. And if you live in an area that has screening guidelines that you've not followed, let's ask ourselves this question of why, right? Are you worried? And I mean that like sincerely. Are you worried what will happen if you do get tapped on the shoulder and we say, hey, guess what? We found something. Is that worse than not being tapped on the shoulder at all? And only you can make that decision. And I know we all have some trauma around us depending on what our experiences have been, what our family's experiences have been. But you do have to ask yourself, if you're young enough to get tapped on the shoulder early enough to change your life, do you want to know? And if it's your value to never have an x-ray, totally fine. I just don't want you to make that decision for any other reason than your values and your beliefs, because the science supports you doing it. The science says that if we put all of those women who are in that fourth decade through mammogram screening programs, we can reduce the risk of some invasive breast cancers by as much as 50%. And so let's do the thing. And let's get curious about what we read online, because I think that that's always a great skill to practice. I hope that this has been helpful. If you live outside of Ontario, what I want you to do is look up the screening guidelines where you live and ask yourself if you're following them. And if you're not, ask yourself how come. And maybe get engaged in some screening, because it can make a massive difference to your lifespan if you connect with it. I'll see you next week. I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.